and they got their jowls in there, and like, just isolating's a pain in the ass. And like, I do that root canal and I think to myself, God damn it, like, thank God I don't have to do a crown on here, because like I don't know what they're gonna do, And I mean,
so we all went to IU dental school, and Mike was in clinic F and I was in G. So we were right. Yep. That just means we were right next to each other, right? And
the good clinics.
I know. The easy they were the easy clinics.
I know, that wing of the dental
not a hallway.
Yeah.
Yeah.
But anyways, we so like in third year, right? At least for us at our school is when you would have to do, if you had to do 20 crowns, right? At some point you could pick and say, I want this case to be my competency case, right? This is the one that I want to get graded on to show like I'm competent in crowns. Okay. And so one of those competencies was also dentures as well, right? And I wasn't there for it, but I remember it became a big thing because, and Mike can confirm or deny this. He's already shaking his head, so I think it's true. But
I forgot about
you forgot about this? This is funny.
So in the competency, like ideally, you're supposed to, get the patient. You're supposed to diagnose it, that they need the dentures. You're supposed to make the wax rims. You're supposed to make the dentures, do everything yourself, right, to show that you're competent in it. But I remember, and Mike can tell the story even a little bit better, but we had heard that he got in a little bit of trouble because he had an outside lab do his wax rims and get stuff set up.
So the truth of it, and
set the record straight.
Yeah. There's always three sides to the story, right? And I'm trying to remember where I got it. It was like Carolyn got it, and I don't know where she got it, right? I mean, who knows where the heck she gets it? They were like pre-made wax rims, essentially. And so rather than you having to like go in a lab and like take this and put it all together, it was like, okay, it's like one thing. And I was like, okay, like, I don't know. I was like, it's not like that's like the denture. That's not like the finished product. It's not like that you don't still have to do a bunch of stupid steps in between.
Yeah.
Yeah, I guess.
So what ended up happening? Because I remember, I mean, we won't say the professor's name, but I remember she had like called you out on it, right? Because didn't she say it was like too good? Is that what happened?
Which is weird that she wouldn't believe that it came from me, but I don't know. Yeah, I forgot about her. Really petite woman. I forget her name now. Anyways, doesn't matter. So I think they just made me redo it. They were like, you have to start over kind of thing.
I know. Nowhere did it say that you could you couldn't use like anything else. And like you said, it's just like a one step out of like 12 or, that you had to do. And they were just like, oh, Mike's going to get kicked out of school or something like that.
So did you admit it? So when they called you out on it, did you say, no. At first were you like, no, I did this. Or did...
No, I don't think I ever remember lying. I was like, well, it is what it is. Like, I mean, I wasn't trying to sneakily do it. That was kind of the thing. It was just like, oh, cool. This exists. I'm going to use it.
Yeah.
No,
that was awesome. It was like, oh, I want to do that too. Like it seemed like a logical, like this is real life. This is how you would do it in your actual practice.
Yeah, I mean, it's hard to take dental school and really apply it to real life and make everything make sense, right? I mean, you were there.
Yeah. So anyways, so once you graduated, did you go straight into endo, or did you do a couple years as a general dentist?
I went straight into endo. That was my goal. Now, while I was applying to endo and maybe not as confident, like I was like, well, getting into specialties is hard, and better. I knew I wanted to do endo, and funny story about that. So I also kind of applied to GPRs at the same time. Hindsight, probably didn't need to do that. And I was lucky enough to get into 2 programs, and then ended up going to Marquette for my 2-year residency.
Because so like our associate, he just got into endo school at like UMKC, like he just found out. And but he said, they let a couple, I think it's like 2 or 3 people they let in, but they definitely want you to have prior experience. Like,
I remember Indiana was like really high on that, like at least a year of whether it was private practice, GPR, and like literally they're like, you should still apply. And then I don't know if they just did that to take my money, but that's, I wasn't getting in I just thought maybe, you know, I'm here. I know some of the residents, maybe, you know, kind of know each other a little bit. So thought that might help, but it didn't help me. I didn't get it.
Well, at least you got in 2 places. That's good.
Yeah.
That's
yeah.
like one place that I got in for dental school. I don't know how you did.
Yeah, I don't even want to talk about that. I applied to, first time applying to dental school, 20 plus schools, not even an interview. Second time applying, 3 interviews after like 20 plus applications. So,
well, you guys are both Canadian. Did you guys both try to go to the Canada route at first and try to get into a Canadian dental school?
Absolutely. The cost is so much cheaper. I was this close to transferring into second year at a dental school if it wasn't for Carolyn.
Oh yeah, I remember that.
Where were you going to go?
U of T.
Oh.
University of Toronto.
Yeah.
Yeah,
cool.
The cost is absurdly, you're well aware.
Yeah.
Yeah, you just have to do what crazy. I did, just do the military thing, or Carolyn, right?
Yeah, so if a couple listeners, and if you don't know, Carolyn is Mike's wife, and she's also a fellow dentist. We all graduated together.
Fellow classmate.
Yeah.
And then Carolyn and I both did the military and just married Canadians. Yeah.
Yeah.
Right. We were just looking to way in the country, so thank you.
Yeah,
I know. Keep us here.
Yeah. Okay, so we thought it would be fun on today's episode to go over with you, being an endodontist, kind of all the shit that us as GPs do that kind of annoy you, whether it's like from how a referral works, like to how, like to any of that stuff, like what we do. And then we also have some follow-up questions for you too on like your thoughts on certain procedures you'll do in endo. So
sure.
Do you want to start with the questions?
Well, it's just okay, we don't do a lot of Eric does know.
Alex
endo.
doesn't do any endo. She's not clinical.
I don't do anything anymore.
She can't claim that she's retired and then talk about
Sure I
endo.
can. I still remember it. It's muscle memory. I remember it.
You could if you wanted to.
I guess. But like I was always one that like a patient come in or whatever and I diagnose, okay, yeah, this decay looks really close to the nerve.
Sure.
Like, I'm not touching it really. Like I'm going, okay, I'm referring you out to endo. I'm not even going to like take out any of the cavities or anything like that. Like I'll let you do that. How much do you love doing that? Or would you prefer if the GP already prepped it and like then assessed and was like, yeah, okay, the restorability is, we're good.
So that's my gripe right there. So I honestly don't mind doing it at all. I'll take crowns off. I'll take bridges off. I know some are like, they'll send them back. Be like, no, you have to take the bridge off. You have to take the crown off. I'm like, it takes me 5 minutes to do it. That's not the hard part. What I don't like is when it says, please remove decay and assess restorability. And I'm like, well, what's your definition of restorability? Restorable. Like, are we, in what community are we working in? Because how many times, like, when I'll get something and the dentist literally already looked at it and said, do the root canal. I'm like, okay. I'm like, you do know that there's like sub-G decay, like furcation involvement, and like prognosis is questionable. Part of that is what I find is like the demographics that you're working with. Like sometimes we'll get, my 2 offices are kind of in 2 different areas, and depending on if we're pulling from like the city or the outskirts determines like, what kind of people you're seeing. And so like when you get people from the outskirts, it's like, if you don't save that tooth, there's no tooth. Like if they get 5 years out of that tooth, that's going to be better than nothing, because they're not putting an implant in, they're just, so in those cases, obviously, like, yeah, I mean, I'm going to do a root canal in some of the situations that I'm like, oh, okay. But it's when I'm like, don't make me make the decision, because
we're totally trying to just palm that off on you.
We try to make you the bad guy.
I think mine always with the endo guys I work with who are awesome, by the way. I'll always say like, please evaluate and like treat as needed. So I keep it very generic.
Right.
It's just a fancy way of saying the same thing.
Right. And I'm fine with that. It's more of the like where it's already like, can you put a crown on that? Like, I mean, you know what I mean? Like, because I'd hate to send it back and like, yeah, I did the root canal. You know what I mean? Like, you could put a crown on there. Is it the best option? Is it going to need crown lengthening? Are there, are you going to have this friggin' plaque trap, food trap that, I see all the time? And I'm like, if you've already had that and now I'm going to take that out and make it even deeper, like, what do you think's going to happen here long term? It's not like, it's kind of common sense. I see everything, right? And that's kind of the thing as a specialist. Like, I see temporary crowns that I'm like, just make me want to vomit, right? And sometimes I think to myself, did the dentist even see that temporary crown, right? Because
no,
like,
it was
I
the
don't know.
assistant.
Well, that's exactly it.
Yeah.
And like, and then they dismiss the patient, and then
Yeah.
the patient comes in and they're like, it's been so sore since they put this temporary crown on. And I look and
yeah,
I'm
it's
like,
because there's just a big glob on their buccal tissue, just like you take it off. Yeah.
Between the between the teeth, the tissue is just bright red, fire truck, Dante's hair red.
Yeah.
Just angry tissue. And I'm like, well, let's clean this up. Let's let it, give it some time. And I'm like, that's not really my job, but.
But I kind of need you to refer to me still, so like I gotta, yeah.
Well, and that's kind of the other thing too, is like when something's referred for a consultation versus, hey, this tooth needs a treatment, and I'm like, there's certain dentists that you're like, no, consultation always first, or we've tried to do a really good job of getting pre-op X-rays, pre-op imaging, just so it's like so I can better manage the patient and manage the patient's expectation and like. Because I don't want to waste their time. I don't want to waste my time. So
like, what are your thoughts on this? So like, how much does it help when we're like, the patient comes in for a limited exam, right? We go through, do all the endo testing on it, and we have our diagnosis in our head of what we think it is, but we're like, we're gonna send to endo, and maybe we're not 100% sure. Do you like in referrals when we tell you like, we think it's specifically this, and this, or are you just like, would you rather have like, patient's been in pain for a week, it's biting, when we did biting or we did a tooth sleuth, it hurt, and it looks like there's a radiolucency evaluated? Or do you want like a full diagnosis, or are you like, screw it, I'm going to do my own diagnosis anyways?
I'd probably say somewhere in between. Like I hate the referrals that come in and it literally just sort like upper right,
circle
or just
tooth.
like it's just one tooth and it's like there's nothing else written down in there. Do you want us to put a temporary? Do you want us to put a build up? And then it's like, there's some dentists where we know every tooth gets a buildup. There's some that every tooth gets a temporary, or then we have to go out and call them and try and get that information. It's like, well, the patient's here now in the chair. Like, I need to know how you want this, or else I'm just gonna do it.
Screw it, do the buildup, get the money on that.
Well, it's not even about the money, because a buildup to me is like nothing and like. Sometimes the root canal is the easy part. It's the isolation, it's the caries removal, it's the buildup. That's the pain in the ass. And I would think as a general dentist, especially when it's like distal number 15 or distal buccal on 15 and they got their jowls in there and like, just isolating is a pain in the ass. And like, I do that root canal and I think to myself, God damn it. Like, thank God I don't have to do a crown on here. Because like, I don't know what they're going to do, And, I mean, they do it, but like, I don't have to worry about tongues. I don't have to worry about cheeks. Like, the rubber dam is my bestest best friend. For sure.
So something in between then. Yeah, that makes sense. Yeah, I mean, I always wonder that too. I was really happy because the endodontist I work with, I had sent him. It was a patient we referred probably like a long time ago, but just with like finances, he needed some time to do it, and then he had done the root canal, and the endodontist like actually removed all the decay, put temporary material all around it, and it was like all on a buckle of a back tooth, and I was like, and it looked nice. Yeah. I was like, oh, this was really nice.
Well,
so I appreciated that.
I've heard stories of like when GPs are like, I don't send to them anymore because it's like they don't remove all the decay. They'll like literally just remove it to do their root canal, and then just like seal it with a temp and want the GP to remove the rest. And they're like, I don't want the tooth to come back with decay still in it. And I mean, you really shouldn't be doing a root canal when there's still decay present.
Yeah. Yeah, I learned that one. Yeah.
What's your other one? You got a bunch of questions for him.
Well, but like, okay, for like hiring, let's say, like your assistants.
Oh, yeah.
How are you, like, because let's be honest, endo is pretty boring.
Oh, our assistants, if you ask any assistant, I feel like in a G. Yeah.
Okay.
So if you ask any assistant,
for us, where it takes a lot longer, I know you're speedy at it, so it's like a little bit different. But like, if we're like, oh, okay, we got to prep the room for.
Oh, if you say like,
prep the room for endo, they're all like,
every assistant is like, no, this is going to be a 3-hour appointment and I'm going to sit there just like handing you a file.
They hate taking all the stuff out. Yeah. And then, they absolutely hate it. So.
Well, that's kind of part of it. And you just said it. I mean, everything's kind of set up already, right? In terms of like, they don't have to drag all this crap over to the room and set it up. And, it's funny because like endo just has so much less when it comes to stuff. Like I remember when we were building our office, they were like, you should have more cabinets and cabinets and cabinets. And we were like, yeah, we love storage. And it's like, we don't use 75% of them. And it's like, I can't move in the room because there's just cabinets everywhere. Like, geez. That's kind of, one thing about endo. It's like, what, other than files, like, what are we really, stocking, a ton of?
Yeah.
Not much. What I find with our assistants, and it is kind of like you said, I've had associates that have been slower. So it's longer appointments. It's more of them kind of just like, in the tooth, like literally just poking, a little bit of ultrasonic poke. And it's like the assistants literally, they sit there and their foot just hangs off the chair, just doing this, just swaying in the wind, and they're just kind of da. So, there is definitely that. But I find also, like, some of our assistants, at least, what they do like about endo is, number one, it's like, we get to focus on one thing, which, for some people, they don't like that. For others, which I love, it's like, I don't have to jump out of the room to go check a hygiene check. I don't have to, like, when I'm doing my root canal, like, that's what I'm doing. Like, sometimes maybe there's like a consult near the end of it or something, or like, kind of overlapped a little bit. But for the most part, like, I'm focused in on what I do, which also means we don't see 40, 50 patients a day. You know what I mean? So we don't flip as many rooms. We don't, we're not, we're not having that kind of the door just constantly going ding, ding, patients for hygiene, patients for, the dentist. And, so we don't have to keep as much staff either, which is nice.
No, I mean, because I see it as the continuum, right? In my head of assistants and what they actually have to do. And in my head, I'm like, okay, if I was an assistant and I didn't want to do anything, I wouldn't be an ortho assistant, because I feel like
absolutely
like
not.
They do 90% of the work, right? Like,
right. Yeah.
Once like it's been diagnosed, it's like, that's like the joke, right? Is that you see your assistant the whole time. And then I feel like on the other end of the spectrum, I always feel like is the endo assistant, where they don't have. So, like, I guess my question is, when you're hiring and you're bringing assistants in, do you tend to hire like endo assistants, or can you be a little bit more lenient on what you're hiring? Because, like you said, it's more like one thing you got to train someone on.
Here's kind of the thing. We've done both. I've taken people from no experience. I don't know what it's like in Colorado, but here, and I'm assuming it's pretty, generalized across the U.S., is finding anyone who wants to work is challenging. Finding anyone now that, because it's become so competitive, they want, they just graduated their 5-week, 1 hour a week course, and they want $24 an hour, and they have zero experience, and I have to train them to do something that I like to do. Now, regardless if you have that experience, I still have to train you to do it how I do it. So there's that, like, kind of catch-22 of, like, they come with experience, but they've been doing it wrong this whole time. Like, we had somebody come from another endo office, and after like a week, I was like, what were their expectations, and what were they okay with this? And like, that again kind of goes to that, like, well, everyone's different, and what I put up with and maybe what they put up with are on two different playing fields, in the sense of I expect you to work when you're at work, and I expect you to learn. Like, I mean, I get it, not everyone's good at, especially taking radiographs during endo, with whether it be cone shot, file shot.
That's got to be the most challenging part. I feel like the assistant is when you've got a rubber dam and you got all this stuff. Like, you probably want to make sure your assistant is trained on X-rays really well.
And the thing is, and like, I mean, it's no different than like when you think about like the DAT and how we have to kind of do those perceptual tests, because like what you have to do is essentially you have to like think about what you're doing. And like, and then they do it, and then they make a mistake, and I'm like, okay, do you see what I'm doing here? Okay, do you see how that makes sense? Yeah. Okay, and then it's like, do you get it? I don't know. So, I mean,
that's funny.
There's no winning. I mean, I mean, I've had one assistant that's been with me for 3 years, and that's the longest. So, and then anywhere from 1 to 2 years in between there, where we just hired another assistant. It's, it's hard to
find anyone, I think.
Yeah, it's
we always joke too. Like, we looked at our, because we use like Gusto payroll forever, right? And so before we sold the practices, we looked through the like previous team members, like, and
history?
It was like, and each one is like 20 per page, right? And there were like 3 or 4 pages, and we were like, holy shit, we've like gone through like 60 people, and so like. You just have to deal with it there, and it works out.
Yeah. I mean, it is what it is. Cost of doing business. It's the fun part of owning an office, right?
Yeah.
Super fun. Yeah. So what other stupid shit do we do to make you mad? Like, so like, for instance, I've never done a root canal, like half done a root canal and sent the rest to you or to an endodontist. Like, so do you get that a bit?
Yeah, I would rather you don't touch it. You know, like, well, maybe do a pulpotomy. Actually, now that you're asking me questions, stories are coming to light in my head, sure. and so the funny thing is, the patients, they don't know what you did. So, like, I had a patient come in and they were like, yeah, I saw the dentist, they put a temporary filling in there, and they wanted you to do the root canal. I was like, okay. The referral doesn't say any, and this goes back to the referral. It would have been nice for you to say, hey, I got inside the tooth, this happened and this happened. Sorry, please finish that. And so we take an image, and I'm like, that looks strange in that canal. Well, it's a broken file.
Yeah.
And so it was an upper molar. Thankfully it was a good patient. It was a younger patient. Visit 1, because now all of a sudden we went from a consult start to like a consult previously initiated with ledged MB canal, broken file in MB2, you know what I mean, and necrosis. And I open this tooth up and take out their temporary. They're still decayed. I work up my distal buccal-palatal canals, no problems. I go down MB, and I'm just halfway, and you just like hit a brick wall. And I'm like, gosh darn it, because sometimes dentists get a little overzealous, or they don't know what they're doing, and they go in too big too quick, and it creates a ledge. And that's a pain in the butt, because now I have to pick my way around it and kind of remove that ledge. And honestly, the file actually ended up being the easy part of it, because it was like right in the coronal aspect of the MB2. And if you know anything about the MB2, it kind of always comes in on an angle because of that like little dentin shelf that's kind of above it. So if you don't remove that shelf, you're kind of working at this angle, right? You remove that shelf, you can go straight in. So like you just remove it and just kind of wiggled out. I don't know what it was, but that wasn't too bad, but that was a pain in the butt. Had another one, same kind of thing. Patient comes in, and you try to set the expectations when there's a separated instrument. Like, I'm not God, right? I'm not a wizard of endodontics. I'm pretty good. I like to think I'm really good, and I take pride in that. But I'm going to do my best. Okay. I had a patient come in, and they look at my name and they're like, but it says you're a board certified endodontist, so you should be able to get it out. And I'm like, wow. Okay, first of all, like the attitude, I don't like it. Second of all, like I'm trying to help you.
I don't have to see you. Yeah.
Right. Well, yeah. And like, you're like trying to set expectations. They're like, well, you'll get it out. And I said, most of the time I don't like to get it out because we're going to end up removing more structure. I'd prefer to bypass it. I think that's a little bit more conservative approach. And if it comes out sometimes, great. If it doesn't, we'll leave it in there and it becomes, part of the seal. Thankfully, and again, in those cases, you're just like, we call them butt puckers, or butt clenchers of like, teeth that you're like patients you don't want to mess up on, right? Yeah. Like the ones that already have like set their expectations that this should be perfect. I was like, buddy, yeah. I didn't put you here, you did. Yeah. Like, you know what I mean? And I'm not saying about the instrument, but it's the fact that you need a root canal. It's like you neglected your health, and we're going to try and bring you back to normal. Mm-hmm. I'm like, it's the best I can do. And again, thankfully, everything worked out well there. Same kind of thing. Another one, patient comes in, it's mid-root, and it's like it's a hand file, and it's like curled up inside the canal system. So I'm looking at that, I'm like, oh man, and like you could see there was kind of like a calcification down the canal. It was number 9, right? So like most general dentists even would look at that and be like,
slam dunk. Yeah.
Right. But the problem is, and this is why another emphasis of mine would be, I take a 3-dimensional image on every single tooth, even number 9. And the reason being is because, you're probably well aware now, you can't see what you can't see. And 3-dimensional imaging is just, makes everyone's life easier. So I took the image and I look at it, and you can see that it's like, it's calcified down to the apex. So they got their instrument in it, and it got stuck in that little calcification. And I guess they were just trying to get past it. That's kind of the only thing I can think of. And then, so it ends up kind of curling up inside of it. Again, this is a patient that comes to me, and she's like, like kind of like already like anxious and like already nervous to be, any root canal. And she's like, you don't have to put that thing on my tooth, right? I didn't like that. And I was like, well, we're going to have to do that. Like, I mean, like, again, I was able to get it out. So thankfully everything went well. Cause I'll set the expectation. You might need an apico. We might, all these things like to try and help them understand that, look, and most of the time they're just like, I just don't want to lose my tooth. You know what I mean? And I get it.
Yeah. On the audio version, Mike does not have his front tooth.
Yeah. Sorry. So other things.
Okay. So here, question then. So did you get a lot of questions like for months after that documentary came out on Netflix where it was like root canals kill everyone? Did you have
It's funny you mentioned that because I remember seeing a post on like, I don't know if it was like on the AAE or like one of those like, or maybe it was just a dental forum that somebody was like, they wrote a good like rebuttal kind of thing.
Yeah.
Obviously you're well aware that it's not on Netflix anymore. And like a lot of the doctors were not necessarily practicing ones. They were like maybe lost their license for doing stuff they shouldn't have been doing. You know what I mean?
And maybe
like
were getting paid. Yeah.
Yeah. I mean, like there's a lot of,
yeah.
Because I never watched it. It was the one that said
it was like called root cause, right?
Root canals will pretty much like kill you.
Is that, or like it leads to
they're associated with
if
you have cancer, it's because you had a root canal on that side.
Oh, gotcha.
Yeah.
Oh yeah, true. So, yeah, all true.
Yeah.
Yeah, no, 100%.
But like, did that hurt your business at all, or did you get more people who were like, I'm not doing a root canal?
I don't think so. I do get some. They're like, well, what's in this material? Well, what's in that? And I'm like, kind of walk them through it and like, try and, baby them a little bit. And if they don't want to do it, I'm fine with it. You don't want to do a root canal. I'm not going to force you to do a root canal. Like no one's holding you against your will here. Like, man, I'm trying to help you out. You don't want to do it. There's the door, right? Like go get it pulled.
Yeah.
Yeah. Oh yeah. So will you ever, do you feel like too with endodontists, right? Like, would you ever get into doing implants or doing more extractions? So like if someone comes in, right? Like if I was a patient and someone and I'm going to see the endodontist, right? And the endodontist looks at it and they're like, the doctor, we took a CBCT and, unfortunately they didn't see this crack or this fracture here. As a patient, if I felt the endodontist was competent, I'd rather just you pull it, right? Or you do the implant. Like, are you seeing endodontists doing that? Or is it kind of like, don't step on other specialist toes? If you like our podcast, check out Alex's newsletter, Just 2 Minutes. It's full of great advice, which makes sense considering it's her thoughts and not me sidetracking her every 2 seconds. You can subscribe at coupleofdentists.com. The link is in the show notes. Now, back to the pod.
To kind of answer your question, me personally, I could care less to extract a tooth. Because obviously the last time I did it was in dental school. And I'll literally tell the patient that. I'll be like, this will be a terrible experience for both of us. Like, don't put yourself in this situation. Don't put me in this situation. And most people are like, oh, thank you. And other people are like, you can do it. And this one guy was like, don't be and he kind of looked around. He's like, a wimp. And I was like, Jesus Christ. I was like, okay. And I was like, okay, no, first of all. I will say, like, and this kind of goes back, Carolyn, my wife, who kind of helps me out with the office, in certain cases, because she loves doing anything surgical, she loves. So if there is an extraction that needs to be done, we'll usually call the dentist and, we'll ask them, right? Sometimes you get a patient where it's like, oh, I'm leaving this weekend, or, I'm heading out of town, and like, they just want it done ASAP, and, dentist is fine. And so Carolyn will take it out. But I personally won't touch implants, not because I don't believe in them or anything like that. In fact, I think implants are great. I think it's the next best thing to a tooth, right? You know what I mean? It's like, if you don't have a tooth, again, you get an implant. There was an endodontist, kind of practicing in the greater Nashville area who did place implants, and I had talked to a couple of dentists, and they literally were like, I stopped referring to him because I would send them for a root canal and they would come back with an implant.
Yeah.
So I think that's kind of like stepping on a lot of toes, especially now that implants have become so popular and more people are doing them. Should they be? You know what I mean? But they are, right? So I don't want to step on anyone's toes. I have had patients come in and they're like, yeah, my dentist wanted you to consult this, and if I need the root canal, they wanted to do it. And I'm like,
oh, so just the consultation.
Okay. And sometimes after I explain to them, they're like, actually, why don't you just do it? You know what I mean? It's like,
yeah.
like, whatever. Like, that's also not a dentist where if they call it Friday at 5 o'clock, I'm not like, working their patient in.
Yeah.
It goes
what do
both
you,
ways.
So is yours, is endo pretty simple too from at least an endodontist office, right? Like, from what you guys are billing and procedures you were doing, right? Like, do you guys just basically like someone comes in, you're just doing endo, or do you guys charge also if you're doing like using MTA? Are there other like ADA codes that you build in as well?
Yeah. So there are, but going back to your point, yeah, there's not much to it, right? Like it's either anterior, premolar, molar. It's either initial or retreatment. It's like limited exam, PA, CT. You know what I mean? Like just the basic codes. We do a fair amount of apicos. I enjoy them. Carolyn will come in and like the best part about our apico dynamic is she'll numb, she'll lay the flap. I'll go in, I'll do the, osteotomy, I'll do the root resection, I'll do the, the repair. She'll put the graft in, suture it up because like she loves that part of things and I like the other part. And so it's kind of like tag in, tag out. Yeah. So, we've been doing more and more and Carolyn, she'll have this like kind of go-getter, like we could do this or we could do that. And I said, oh gosh, like stop. Like we did this one surgery where it was like, the lingual of number 9 had a defect like on the root, so we had to do like a flap on the lingual and do the root canal and then repair. I was like, oh my goodness, like we did it and it turned out great, but like sometimes I'm like, don't make my life harder than it needs to be.
Oh, I feel like if Alex and I had to do that, what would happen is I would numb the patient up. I would commit to help with other things, and then I would try to do it. It wouldn't go well, and then Alex would fix it. That was what would happen.
Yeah,
I get the numbing down for you. That'd
thank
be
you
good.
for numbing.
Yeah.
Yeah, I mean, numbing's nobody likes numbing. I find because like that's the person who like the patient like hates at the time, right? Like I mean,
I love it.
So yeah.
Well,
but
do you remember too? Do you remember some of like in school when we would go up to, I think it was like Regan Street, which was like an oral surgery clinic, right? That was kind of took care of either maybe more of like a low income population, right? So they would have then dental students, right, take care of them. And I remember one of the residents there when I remember watching him, and whenever he would numb up and he would give like blocks, he would just shove that stuff in so fast and and deadpan would just go like, I'm sorry. And it would say the same thing over and over again. I was like, you are such a stereotypical oral surgeon.
I think that's like an oral surgeon thing. Because like, I feel like that wasn't, and I do recall that like literally, but I'm sure like you probably want to make it a comfortable thing, especially when patients are like, I hate the numbing, it's the worst part. And then after they're like, that's it. You're like, see, quit being such a freaking baby.
Yeah.
I know.
You're an adult.
Yeah, but do you still have to give like palatal injections? I have not given one in like I don't think I've given one ever since we had our practices.
Yeah,
do you have to do those a lot?
That's the one kind of crappy one that I have to give, and I'm literally I'll be like, okay, this is gonna pinch for a second, blanch the tissue with my mirror.
This is gonna pinch for a second. I remember I had a patient. He was like, "You dentists always say that. It's not a freaking pinch. It hurts."
I'm here to help.
Yeah.
Well, the other option is I put the clamp on and it's like digging in your gums, or you have a palatal root that's like way over here and that palatal root didn't get numb. And it's like,
what do you want? Yeah.
Right. Again, you put yourself here.
Yeah.
Yeah.
I still always get patients that'll ask me to like, is there another way to do it without a shot? It's like,
right.
No, not yet.
Did you guys use did you talk about the wand? Was that you guys talking about the wand?
No.
Or you ever use that?
I used to see it. Remember, like, when we went to the midwinter,
fancy.
like, when we graduated, that's when wasn't it like that Antura company or something? There was a couple companies that came out with
that
like
was
those.
Different, I think.
That was like buffering solution,
Yeah.
but then there was like the wand where it was like, oh yeah, you can do it that way and it doesn't hurt at all. I don't know, man. Like, I literally, or like, you had the Vibroject too.
Oh,
thing.
yeah.
Right.
Yeah, I did have a Vibroject. Yeah.
I don't know. Like,
I liked it. I mean,
yeah, it just seems like a lot. And honestly, like, I just put in good numbing gel in there, and I even got away from like the compounding pharmacy one,
I
and just
you were using that.
Alex was.
I like it. I really
that
do.
stuff will like. I remember I had it on me once when I had my TAD put in. It'll slough your tissue right off. Like that stuff.
It will. Yeah, you do have to be careful. But like I numbed my when I was testing it out, I numbed my front tooth with it.
Oh yeah,
just
and it actually
topical,
numbed
and
the
I was
tooth
like,
a little
holy
bit.
shit.
But honestly, like I don't know. I just go in now and tell patients like, yeah, this is the worst part. This is the part that hurts. I'll do my my best, but you're still gonna feel it. And if I just set that expectation. And they're like, they already come in knowing it's going to hurt probably. So like, why am I wasting my time and energy trying to like change that. Like you still like I inject slowly and I'll tell them that like you're going to feel when the medicine's going in.
Yeah.
And I'll go slowly. I'll do it. I'll make sure I put topical on, right? Like I'll talk them through it. And I feel like if you do more of that from patient management, it's better than like saying it's like crap when people are like pain-free dentistry, right? Like I don't know. That's my soapbox on that.
Yeah.
Mm-hmm. What about so I know Eric was talking about coding and stuff. I know like with, so we take like PPOs.
We do as well.
Okay. So sometimes you have to be a little creative with billing, right?
Yep.
And it's like, oh yeah, there's a desensitizer that we put on, or these are like, we try to break it down. So, obviously we can bill insurance as much as we can ish.
Right.
Ethically. Right.
Yeah. 100%.
Are there things like that within endo?
Yeah, they're like non-coded stuff like you can do, and you can say, hey, this patient,
So one thing we do is like we'll charge for an additional PA, right? It's like, hey, we took one and then we take an angle or something like that, so we'll bill insurance for that, right? It's usually not much, right? It's like $15, right? It's not saving me, it's not putting a down payment on my car, I'll tell you that much. Now what does grind my gears is, okay, so for example, that separated file inside a tooth, right? There is a code, whatever it is, 3333 or something like that, or 3331, and it's for obstruction, right? An instrument that I have to remove, which requires more time, it requires maybe more different tools, and you can charge it to the patient, especially if they don't have insurance. But once insurance gets involved, they will, what we'll get is, this is considered inclusive of the treatment, and then they deny it. And it's like, you send them imaging, you appeal, you kind of explain to them, and ChatGPT has been really helpful for that, of like the importance of why this was needed. And, same thing goes for, it's like, I think you said even MTA, right? If we're doing perforation repair or like open apex cases. So sometimes, especially with kids, like some of the stuff does not pay anything. If you're trying to do like just a pulpotomy, and it's like, great, I had to work on a kid, so that was harder. Like, the dealing with them, and then the actual procedure, it's like, so for that procedure, you get $200 or something like that for the pulpotomy. It's like, well, what about the repair material that we use that for one, like, a syringe of it costs $200. You know what I mean? Yeah. It's like, we try to do that, and they're like, no, that's considered inclusive. Like it's difficult, obviously. And I think you mentioned this recently about the whole, just get out of network with them. Everything will be fine. And it's like, how many times.
Well, yeah, that's tough for you guys, right? Because like your business is based on getting referrals from general dentists. Right. So like, I've used the same endodontist since we opened, right? Like they're really good. But if they suddenly like we're out of network, I'd still want to send patients there, but patients aren't going to go there. Like, it's not going to happen.
That's exactly it. Well, we'll get some that will, or like maybe they have other network benefits or something like that. And then others where they're literally like, okay, I'll go somewhere else. And it's like, I mean, personally, if my, physician was like, hey, you should see this person, they're the best, I would be like, okay, I think that's probably a good idea. Like people, I mean, you're well aware it's more about who takes my insurance than it is about, because they don't know anything about quality of the patients, that's for sure.
No, and they haven't met you before, right? So even if I say it, like not that you guys are, I guess it's not like you guys are a commodity in it, but I think if you guys are already self-selected as board certified endodontists, I think there's already like a high standard that people assume.
They're not all board certified.
Oh, well, assuming they're all board certified.
Well, they're not.
Wait, there aren't? So what's the difference on all that?
So that's the thing. And this goes back to Miss Canada over here. In Canada, to be an endodontist, you have to be board certified in Canada. So, you take that exam just like you would your dental one. Here in the U.S., when you graduate, there's no like ADEX or what do you call it, CERTA or national
like revs or NERVs or
right. There's nothing like that for endo. So you just graduate and you're good to practice. You don't have to become board certified. So to become board certified, you have to do additional tests to, a written, an oral exam, and then a case. You submit cases. So, it's kind of a way to distinguish yourself. It's also important for the specialty. So I don't know if you know this, but in order for a specialty to exist, you have to have so many board certified specialists within the field, right? So I don't know what the number is, like 20% or 25% of the specialty needs to be certified. And I'm from what I understand, that's irrespective of endodontics, right? That's pediatrics, that's oral surgeons, that's.
So what percent do you know? Because I equate this a little bit to like the ADA, where like nowadays everyone's like, I'm not joining the freaking ADA. Like, what the hell do they do, right? Like, is that happening within specialties too, where people are like, because you have more GPs doing it now, right? So do a lot of people graduate from endo and are like, why am I gonna go do this extra stuff if it like maybe it doesn't matter like it did in the past to like the public perception?
Right. Well, and especially for specialists, we have our own kind of organizations, right? We have the AAE in endodontics, they have the AAO or something, all the, oral surgery, or orthodontics, they have their own group, right? So, and that you pay your $1,000 a year to be in that group. The one thing I have noticed is that in order, like at least here in Tennessee, in order to be a member of the Tennessee Dental Association, you have to be a member of the American Dental Association. And I don't know if that's a universal thing, but it's kind of like, I don't know if that's how they get you.
I'm sure.
But yeah, part of me is like,
I'm probably more of a conspiracy theorist with that stuff, but that's just me.
No, it's for the lobbying, Eric.
Yeah.
And all the changes that you've seen.
Yeah, right.
I don't know. Ask Zundo. He'll
I know, right? Yeah, we can ask Eric who came on before his thoughts on that. Yeah. Okay. So would you have passed me if I when we took the rep, right? So going back, this is 4th year, right? We're trying to graduate, and we took the rep, right? Did you take that too, or did you take the NERB?
I took the NERB.
Okay. So we had to go to Louisville for that, right? Because Indiana didn't offer it. Even when we tried to ask them to, they didn't want to do that. But so anyways, we went down there, and for the reb, the endo part is you're just working on like a tooth, like outside, right? You just an extracted tooth, you put it in some type of cement, and then you just do the endo on it, right? I think in a dentiform, right? Which is like, I guess everyone here should be a dentist that's listening or know what that is, but if not, it's like fake patient mouth, right? And so I was going through and doing it, and you're already like stressed out in boards, right? Because you're like, shit, I'm gonna fail all the time, or maybe just me because I don't have confidence with it, but I remember doing it, and I was like, "Where's the rest of the file?" When I was in the middle of it, I was like, "Oh shit!" I took the file separated, and I remember going up to like the examiner person. I was like, "I just did this. Do I like stop now?" And then I took an X-ray, and it separated like nicely, like meaning like it was right near the apex. It didn't look bad, like it looked filled. In my head, I was like, are they going to notice? Because it's just an X-ray, right, that you're submitting. And so I told him, and he's like, that doesn't mean it's an automatic fail. And I was like, sweet. He's like, just fill the rest of it, right, up. Yeah. And then, I ended up passing it because there really wasn't, like, you could see a tiny little gap, like, from the separated file to where it was. But is that considered passing, or would you just be like, fail this?
Well, see, it goes back to the diagnosis. Was the tooth necrotic? Was it a vital case?
It was dry.
It was in cement. Yeah,
I know, right? Yeah, but like that goes back to like instruments separate, right? It's kind of the cost of doing business. Like, if you say you've never done it, it's because you don't do root canals, right? It happens to me as a specialist. Obviously, maybe not as much, or I wouldn't like it to happen very much. But, I think they say like only like 3% of separated instruments lead to issues. Now that obviously probably encompasses a lot. And this again is according to a study, but like there's a lot of, when did it happen during the procedure? Was this the first file that went in there or the last file that went in there, right? Like, is there tissue or, necrotic debris in that area still, so theoretically then, as long as it's like entombed within the tooth, probably fine.
Yeah.
I'd pass you, Eric.
Thank you.
Anyways, did you pass?
Yeah.
Yeah, you did. Yeah.
I did on that. Yeah.
Which is good. Yeah. Was that the last endo you did though?
No, I did a couple more. Remember when I would call you?
Oh, I remember.
Be like, why
were they
am I doing
in
this?
a panic.
Well, and sometimes I ask myself that when like, and I'm sure this is like this with anything you do. Because I'll have some GPs and they'll almost come to a realization that they should like not do endo when it's kind of like you said, it takes me 3 hours and maybe I start a case and I can't finish it. So I just made no money for that 3 hours. And it's like, I'm really good at doing crowns and I'm really fast at doing crowns. I'd almost rather focus on that. So I have a couple GPs that like, they literally would message me and be like, I'm done doing root canals. You do them all, build them up, send them to me, and it's a win-win. And they're busy enough that they don't need to do root canals. So that's obviously a big part of it. I will notice sometimes when we get slow, and so do the general dentists. Part of the reason we're getting slow is because they're now doing root canals that they may have referred out in the first place, which, again, I'm not saying general dentists can't do root canals, but some of them can't.
So have you ever thought of like, because like a lot of practices now are trying to be like these super GP practices, right? Where they're these like one big mega practice and they'll keep everything in house.
Yeah.
Did you ever consider doing like traveling endo and like work with some big offices and be like, I'm coming in? Okay.
I did for a couple of years. So when I graduated my residency, that was when Carolyn was in North Carolina, right? So she was paying back her military time. She's doing her thing in Fayetteville, North Carolina,
jumping
Fort
out
Bragg.
of planes.
Yeah, exactly. Yeah, she liked it. But yeah, so one is I was like, I need to find a job, right? And usually the easiest thing to find jobs in are sort of the traveling endodontist in bigger corporate type settings where, you bounce from office to office. And I will say the cool thing about that was I did not have to market, right? So I didn't have to go and woo any of the dentists. That was good. I didn't really have to, I don't even think I had to do like letters or anything back to the dentist because everything was like in their chart, right? So it's like, if the dentist wants to see what happened, they literally just look because they have access to those same charts. And you show up, the patients, are scheduled for that day. Now what sucked, it's kind of like you said, because I was traveling, I had to bring stuff back and forth. I was working in a GP office that wasn't necessarily set up for endo. So it's kind of like you said, when you're like, we didn't like endo or the staff don't like endo because they have to set everything up. Well, that's what we had to do at the beginning of every day in a different location. One place I worked at, it was just between two offices that I worked. I think there were 27 locations total that would refer to those two spots. I did the same thing when I was out in Washington State. There I went to 5 offices. Like sometimes it was like one every other week or one once a week. So there were good things and there's bad things. Now what I've noticed when I am now practicing and I see stuff that's been done at another office and now comes to us is that because that endodontist doesn't necessarily have to woo the general dentist, their work becomes sometimes a little bit shoddier because they're like, well, if I just do a crappy root canal and the patient's fine, the GP doesn't really look at that or care because they're like, wow, the root canal was done. And if the relationship doesn't really become separated because they're like, you still have to keep the stuff in office. Right?
Oh yeah, that was the worst. Like when I worked at a bigger corporate office while our office was being built, that was always frustrating as like the GP where I felt like the specialist could come in, do stuff and not have to deal with any complications, right? It was like, it would always get put back on me. And I was like, I didn't even do this. And now I'm not wasting because you're still taking care of the patient, but like, if we're talking
post-ops,
if we're talking like purely just from like being productive, it was such a waste of time to do a post-op for someone else's work. I was like, I didn't do this. Like I wasn't in there. I'm not the best to do that. I'm not the best to even tell you what's really going on.
You don't know what they told the patient, like in the sense of like, hey, was this questionable? And like they still did it, or I've had that.
Oh yeah, it was definitely like OSs. I was always like, man, their gig is like sweet. Like there was one guy I think, right? He had maybe they took out like a wisdom tooth, and the medications he was on, he had gotten like a really big like blood, like a kind of like a blood blister in there, right? Like huge, right? Like massive, and it was like. To me, as a general dentist who like never sees that stuff, like, or the other dentist that was there too, we looked at it and we're like, yeah, like I know what this is, but like I'm not equipped. I don't know. Like, does he want me to cut this off? Does he want me to like drain it? What am I supposed to do? I have no idea. Like, I don't see this ever. And of course, like, there's no oral surgeons there. And then the oral surgeon's like, oh yeah, just do this and this. It's like, yeah, that's easy for you to say, man. Like, you got to do this and not deal with any of it. And I was like, oh man, that's such a sweet gig. Like, do all the work, no complications that you have to deal with.
Yeah, but even like traveling to other GP offices, like, don't you guys rely, or maybe now, like, rely on your microscope?
Oh yeah.
So we would have to, in those situations, you'd have to, like, one place I went, it was like your optics fit in a suitcase. And so you would just show up and they had like a stand that you would just put the actual microscope on. So yes, because I was obviously at that point, it's like, I'm not working without a microscope. Like that's not really like, it's like a non-negotiable. I moonlit during my residency, which was cool that we could do that because I made some extra money. Obviously I didn't necessarily have a microscope though at most of the place I went. I was just using loupes, and I look back and I'm like, I don't even know how you do that. Like it almost baffles me how people, like, I mean, and some endodontists don't need microscopes, and they do a beautiful job. But like, I'll like sometimes not look in the scope, and I'm like, I can't see anything. Like it's like it's darker. It's like I don't know if I'm just getting older, my eyes suck, but like like seeing with endo is I mean, the scope just makes it easy.
We all know Eric wants more friends. If you're enjoying this episode, share the podcast and then tell them to DM Eric so he can hit his quota of 1 new friend per day. Now back to the episode.
So how much going back to dental school, right? Because you ended up doing you did pretty well in our class. I remember when they went through and did our rankings at the end. There's, I think everyone knew you were smart, but I didn't know you
lazy.
But not lazy. You were you were one of those kids who was you under the radar were really smart, but understated it a little bit, right?
Because I like to have a good time.
Yeah. But anyways, my point is, do you feel like if you weren't I want to do endo or I want to do a GPR or it's something that requires that, would you have focused as much on this is what the grade is? Not saying that you would have done a worse job in dental, but do you think that pushed you to say dude, I got to figure out a way to go from a B+ to an A- here?
I think it was a combination of that. I think it was also after college, because college I definitely did not live up to my potential, which is kind of goes back to why I didn't get an interview the first time I applied. You know what I mean? I think it was to prove to myself maybe a little bit I can do this and I can be near the top. I know Alex and I used to study a lot together and share notes and stuff, and I felt like you were very similar like that, where it's because I felt at one point because I even look back as I was thinking, I was I remember Alex telling me at one point she was interested in endo, and I think at that time I was I think maybe I'll look into endo too. Yeah. I had thought about it, but I was I felt like you were kind of interested. And then that's, I think, also when you were actually cosmetics. I remember, you kind of had made that switch a little bit.
Yeah.
But look at what you could have been.
I know. I could have been an endodontist and still had a practice.
Yeah. See?
Yeah. It doesn't suit you though, practicing, does it?
I don't want to work. I'll work on everything else. Yeah.
Teach me that one. I want to know that one.
No, I remember our version was just the group I would study with too. I was now I see why maybe we didn't do as well in first and second year because we were not focused at all.
Well, No. C's get degrees.
Yeah.
Yeah, you never looked at any of your grades. He doesn't even know what rank he I
have no idea ever what a rank was. I have no idea. I mean, I know I passed everything because I would check grade. I knew what my grades were on stuff, and then when I would I would see what they were, and then when I would talk to other people, I would kind of compare and be I'm somewhere around average-ish on it on what people are getting. It's not I was getting A's all the time, but I also wasn't getting a D in something and had to remediate,
now,
a bunch of times.
If you would have wanted to specialize, would that have been any different? Or is that the reason you didn't specialize, or did you just not have any desire?
Oh, I mean, I don't know. Looking back, I always wonder if
I don't know.
I don't know. Fourth year, remember? Did you do that thing with us where we met with the dean and we were talking about the business part of dentistry?
Sure.
I think I knew super early on that I was how can after the military, how can I do the business side of it and run practices? I don't think I ever wanted to do 30 years clinical. And so the idea. I know,
but you also don't like to get out of your comfort zone at all. Versus I'll I'll do this endo. Let me try it.
Yeah, you have more of a cowboy personality.
I mean, a little bit.
That,
yeah,
right?
yeah. It's you got to do it. You got to start somewhere. And
that's exactly it. And then it becomes easier. Weird, right?
Yeah. And then, yeah.
I think my fear was always on it's on a real person. So I always felt so much pressure that if guilt. I did, right? If I did something wrong on someone, I was I could have just if say the endo didn't work or something happened, you're and now this person lost a tooth, I was I just ruined their life, right? So I think I think I would over
worry,
estimate and over worry about that stuff. So it prevented me from doing that, I think.
I wish there were more people out there that at least had that little bit of feeling about if I do this crappy work that'll affect someone's life, because I don't think a lot of people out there have that empathy or whatever you want to.
Yeah, probably.
Yeah, but I get your guys' perspective too. You guys were all right, I got to try it. There's no other way, right, than just doing it. But yeah, you guys both did that more. But you did that with surgery too. I didn't know. I didn't know you wanted to potentially do.
Yeah, yeah. When we started endo in third year, we got into rotations and stuff like that. I was oh, I could do this thing that's kind of built for like OCD people, like
right.
you know, like this.
Yeah, but like, how do you
right
like,
up my alley?
like
you know?
so like personality where like, I feel like when we were in dental school, like we had a good group of friends and stuff like that, but if I would have pegged you just from knowing you, I'd have been like, Mike likes to do a lot of different stuff, right? Like, right? Like, I would have thought like Mike with endo, he would find that so freaking boring of just doing the same thing over and over again. Because you seemed a little bit more like how I could be, where it was like, all right, what's over here? What's over here? What's over here? Let's do this. Let's do this. And you like to do a lot. So I always thought it was interesting when I was like, oh, Mike's doing endo. Like, why?
Yeah. You know, it's funny because sometimes I do think about that when I'm like literally looking at this bricked tooth on an 88-year-old patient that like there's no sight of a canal in sight. And I said, why did I do this to myself? You know, and then I turn and I say, well, if I can't do it, nobody's going to do it, right? So it's like, you know, I'm going to do the best I can. And I've come to that point. It only took like 10 years of doing endodontics to be like, you know what, this isn't that bad. And you know, when I look at that tooth, I'm like, it sucks, but I don't like stress about it. I don't like lose sleep over it. I like go into it being like, we're going to find this. And if we don't, we'll figure it out.
Yeah.
So, you know.
Yeah, but that's just from you getting reps in, right? And just getting
with
it.
Yeah, for sure. And for some people, perhaps I've met a few because like, well, you know, I've been trying to find associates and, you know, just like staffing, finding the right person and, you know, is not necessarily the easiest thing because I found people like that come straight out of school. And then I'm like, buddy, you gotta pump the brakes a little bit. Like you're being a little too wild in the sense of like, you can do anything and then you botch all this stuff. You know what I mean? And like, now I'm cleaning up, but
yeah,
this goes both ways.
Yeah. Nice. Well, thank you for sharing with us all the things that we do that are annoying.
Yeah. We are not convinced. Eric is not convinced that he will do any more endo. No, of course not.
So, well, you're what? How many days a week are you practicing?
I'm doing like 2 longer days. So it ends up being around like 20 hours a week, right? I mean, that's based on contractually, right? That's what I'm doing. But I mean, what I always did, like I said, the associate we have he just got into endo. So like, it's been nice because what I did is early on realized I don't want to do all these extra procedures. Why don't I just hire someone who likes doing them, right? Enjoys it. They're going to get paid more. Like if I was an associate coming in and working with me and I like dentistry, I'd be like, this is the perfect owner. He doesn't take stuff from me.
Right.
He doesn't try to steal all these things. Like, you know, he'll do a lot of the bread and butter stuff. And I've gotten efficient and quick with those, like with crown preps, all that kind of stuff is fine. But like, I'm not going to do a lot of that, I don't know, specialty, right, stuff.
Yeah.
And they like doing it. So it's like, it's a pretty good relationship because there's never, I feed them, right, a lot of stuff, which is good.
Right. I mean, yeah.
But even like the guy that we work with too, like he still knows like what he thinks his limits are. Like if there's a case and he looks at it and we don't have a CBCT, right? So he'll say like, you know, if we got one, then, you know, I might do more, right? But if we don't, and it looks like this, I'd rather just send to the endodontist. So he's good too about like not pushing too much, right? Which is, I think, which is good for the patient.
Yeah.
Good.
Yeah. All right, cool. Well, you got to come on and we'll figure out other stuff. We'll just spend an hour talking about all our
reminisce about other dental school
stories.
Stuff. Yeah.
So no one else listened to that except for us. It's just for us. It's not for you.
Yeah, right.
It's just our normal call that we just talk.
Right. It'd be like sitting at Tom's table, dinner table again.
Yeah. Cool. Well, thanks for coming on, man.
Bitch and complain. Of course. It was fun.
Yeah.
Cool.
Thanks,
all right. We'll see you.